Welcome everyone to Tea and Chocolate, and today my special guest is Dr. Paula Gordon, and we are coming to you from Vancouver, BC, and I will give Dr. Gordon the floor, and she can introduce herself, and we can certainly talk about a very interesting topic today that should be on the top of not only women's minds, but also men's, and from the perspective of this will affect in some way your mothers, your daughters, your sisters, your female friends. So Dr. Gordon, thank you so much for taking some time with us today.
You're welcome.
Okay, please.
So you asked me to explain what I do.
Yes.
So I'm a radiologist. Radiologists read x-rays and CT scans and MRIs and all that stuff, and we do procedures. I'm a breast radiologist, so many years ago, I focused on breast imaging. So I don't do the CT scans and the angiograms and that kind of stuff anymore. I do read mammograms and breast ultrasounds. In my practice, I don't do breast MRI, but some breast radiologists do. And I do lots of procedures. So mostly what we call image-guided procedures. So if there's something we see on an imaging test, like an ultrasound or even a mammogram, we use either image modality to aim a needle into the right spot to take some tissue that get looked at under the microscope by a pathologist. We do that with local anesthetic. So that's what I do.
And what made you decide early on that you wanted to focus on breast health?
Oh, it's a bit of a long story. Well, when a person trains to be a radiologist, they can go into practice and be a jack of all trades. Or they can focus in on an area, and the area I focused in on originally was ultrasound. And if you want to do extra training after you've qualified to hang up your shingle, you do what's called a fellowship. So I did a year-long fellowship in ultrasound, which would have left me qualified to run an ultrasound department, let's say, be the head of ultrasound. There were no jobs doing just ultrasound, so some of the first jobs that I took, one of them was one of the places I still work, which does a very high volume of mammography. And mammography wasn't really part of the residency even in those days, but we had some teaching. And I ended up working part-time for the woman who had taught me how to do mammograms. And breast ultrasound wasn't really a thing then, but I worked part-time doing all these mammograms. And then the other half-time I worked in a hospital where I did a lot of ultrasound. And in the mid-1980s, the technology advanced to the point that they made the kind of probes that you need to use to see structures close to the skin. We used to call them small parts. So, for example, before those probes were invented, you couldn't do a breast ultrasound, you couldn't do a testicular ultrasound, you couldn't do a thyroid, stuff we take for granted nowadays. And so we got one of those machines, and I thought, why don't I try to look at the breast with this? And I did, and it worked, and I started doing ultrasound guided needle biopsies and so on in the mid-1980s. And it was having those two skill sets, which usually didn't come together in the same radiologist. The people who read mammograms usually read chest x-rays, and the people who did ultrasounds did pregnancy ultrasounds and abdominal ultrasounds. But to have the skill of having done this extra training in ultrasound, when the right probes came along, I was in a position to apply the knowledge I had from doing all the mammograms, and was sort of there at the beginning of that specialty, the breast ultrasound and needle biopsy specialty.
Mm-hmm. So you've seen quite the evolution, haven't you?
Absolutely.
A necessity, is it not?
Sorry?
So it's a necessity. In order for you to diagnose, it's been it's been a progression. So it's
a progression, but the people who study radiology now,
yes,
learn how to do everything that I do. They just didn't have to pioneer it through the awkward stages where the equipment wasn't so great. Mammograms have come a long way since the early 1980s when I started practice, and ultrasound as well. The machines were fine back then, but boy, are they amazing now.
Are they?
Oh yeah.
So when you say that, because there's a lot of, as you probably know, there's a lot of controversy around mammography regarding the radiation. I'm not sure if you know that. No.
No, no, no. Well, don't say, don't I know that? I'm shaking my head.
Oh.
There should not be controversy. The dose of radiation used in a mammogram is negligible, especially if you limit it to women. Well, really, it's the adolescent breast that we don't want to do a mammogram on. Really, if we had to, we could do a mammogram on a woman in her late 20s or early 30s. We try not to, but absolutely by age 40, it's perfectly safe to do mammography. It's almost a negligible dose. And when we talk about doing any test, we're talking about balancing the benefits and the risks. And when we're doing, for example, screening mammograms, looking for early cancers, the benefits far outweigh radiation isn't even on anybody's list, quite frankly. Even task forces and so on that don't recommend mammograms starting at 40, it's not because of the radiation.
Okay.
So let me put that one to bed. Radiation, no big deal.
Okay. Well, I appreciate that. Thank you. So just a quick thing then. So in terms of like mammography becoming a bit more, or rather it's been more refined and, today, what sort of feedback are you giving the creator, the manufacturer, that they enhance the tool?
They don't need to get the feedback from me. They have people like me working for them. And the dose is lower than it used to be. The resolution is higher. The image is clearer, especially since 2012 when we've had 3D mammography. That adds a whole other layer, excuse the pun, of clarity to the mammogram. It's unfortunately not widely available in Canada, but it will be here.
Yeah, it will be. So let's talk about, you are a medical advisor for Dense Breasts Canada. And this is where you are a patient advocate for this particular, I'm
an advocate, but they're the advocates.
Yes, okay.
They're advocating, I'm advocating too, but the kinds of things we're advocating for, and by the way, full disclosure, this is a volunteer gig for me. I'm doing this because I'm thrilled to help. The information that they're imparting when they advocate has been around for decades. Decades. We've known since 1976 that women with dense breasts are at an increased risk for getting breast cancer. Okay, so task forces and politicians, they don't listen to doctors. We've known, but they listen to women, they listen to voters. So now that there are women willing to speak up, and I must tell you, these women who are advocating, they are very brave. A lot of women, once they get through breast cancer, they just want to put it behind them, go on with their lives. And these women are standing up and speaking out and telling their stories for the benefit of other women. And I'm just feeding them the science that's been there all along. Some of the science I've participated in, but lots of it's out there.
Certainly. So it seems like it's been a lovely partnership. Between the two of you, the patient advocates, the actual patients, and you are there to support the journey as well. Would you not say?
Yes.
Okay. So in terms of this information that you've known for decades, since 1976, how have you, did you have the support of your colleagues? What did that look like? Like, how are you an advocate in the system that you work in?
It depends who you're talking about.
Okay.
Doing the work costs money, but the people who are not promoting what's best aren't saying, oh, well, we're not going to do that because it costs too much. And so when I state the facts, they don't argue with me, but a lot of people are willing to just practice the way the system is set up. And I guess what I'm doing that other people aren't doing is saying, no, that's not good enough. We can do better. We can save more lives. We can save more breasts.
Okay. Do I'm assuming that you feel safe in your world, in the physician world, to express that freely. Okay.
What are they going to do? Fire me? There's a shortage of specialists that do what I do.
Okay.
I'm also retirement age. If they can me, I'm okay.
Have you passed the baton, or will you pass that sort of to anyone at some point?
I have passed the baton of leadership of the breast program at BC Women's to one of the women I trained, who's amazing. So she's doing all the administrative stuff. Yay, I got out right in time. There are loads of people who could do it, but they're just busy with other things. My kids are gone. I have time to do it, and I have the energy to do it, and that's why I'm doing it.
Okay. Let's touch quickly on what dense breast is and why it's important for women to know what their density is and to ensure they follow through, or they have the right support system that they ensure that they get followed through.
Well, it depends who hears this, because we're so lucky in British Columbia.
Yes.
Thanks to the work of Dense Breast Canada and our health minister and the women MLAs who bugged him, that we were the first province in Canada in October 2018 where women were told after a routine screening mammogram, it was in the report that came to them, to tell them what their breast density is. Breast density is a measure, if I want to put it in really simple terms, of how white the breast looks on a mammogram. All women have in their breasts fat and breast tissue. Fat looks dark gray or black. Normal breast tissue looks white. And some women have all fat and no white at all. And there's a spectrum. It goes all the way up to all white and no black. And they're all normal. There's a huge variation in what normal breast tissue can look like. Cancer is white and normal breast tissue is white on a mammogram. So if a woman has lots of normal white breast tissue, she could have a cancer and we just won't see it because it's masked. The expression we use, it's like a snowball in a snowstorm. It's hiding amongst the normal tissue. And so even a big cancer can be missed. In a woman with fatty breasts or non-dense breasts, because there are 4 categories, the lower 2 are non-dense and the top 2 are dense. Woman with non-dense breasts, we can see even small cancers easily. And women need to know if they have dense breasts or not, because if you have your mammogram and it comes back negative or normal and you have dense breasts, it doesn't necessarily mean there's no cancer. So the women who are part of Dense Breast Canada are women whose cancers were diagnosed late. They missed the opportunity of finding them on a mammogram because they were hiding in dense tissue. And some of them, by the time they're diagnosed, they're stage 4. So the typical scenario is a woman goes for, well, let me tell you the story of Dr. Nancy Capello. Nancy was a PhD in educational leadership in Connecticut. In 2004, she faithfully went for her annual mammogram and it was negative. Within weeks, she found a lump in her breast and had an ultrasound and had a needle biopsy. It was a stage 3C breast cancer, and it had already spread to 13 of her lymph nodes. And she said to her doctors, how could this happen? I just had a normal mammogram. And they said, well, you have dense breasts. We know that dense breasts can hide cancers. And she said, whoa, wait a minute. You knew something about me that you didn't share with me that I might have benefited from? And she went, her family doctor told her that, her surgeon told her that, her oncologist, everybody said, yeah, you've got dense breasts. And none of them thought there was a need to change, that the women should be notified. So the medical system pushed her away. she went to the political system and she lobbied, and Connecticut was the first state to pass legislation requiring that all women be told something about breast density in their mammogram report. And Connecticut was the first state to start doing breast ultrasound as a screening test for women with dense breasts. And they've got piles of data, and they're finding 3 to 4 cancers per 1,000 women that they screen with ultrasound. And those are cancers that were missed on the mammogram. So that's 2009 was when they started screening. Nancy was diagnosed in 2004, but that took her 5 years. Dense Breast Canada hasn't been going for more than a few years now. And they've achieved so much. There's much more to do, but British Columbia has now, and we didn't have to go the legislative route because the health minister basically told the cancer agency who runs the screening program, you've got to start telling women their breast density. And in the meantime, New Brunswick, Prince Edward Island, and Nova Scotia are notifying women. But we got a lot of provinces that aren't yet. Alberta announced that they were going to, and I think they just got caught up with the COVID pandemic and things are kind of on hold. But there are provinces where they're not even using the 4-category system of breast density, which started in, I want to say, around 2008. I may be wrong. No, sorry, it was the 80s. So there's still provinces that don't use a 4-category system. And some of them are telling women that they're dense only if they're in the highest category. And the danger with that 2-category system is the women in the 3rd highest category, which also have dense breasts, they're not being told that their breasts are dense. And getting a negative mammogram report can give a false sense of security. If a woman doesn't know she's dense and she gets a normal report, she figures, I'm done, good for another year, or in some provinces, another 2 years. And she risks having what we call an interval cancer. That's what Nancy had. When a woman's diagnosed with cancer, after her most recent mammogram was negative, we call it an interval cancer because it was found in the interval between planned screening mammograms. And interval cancers tend to be bigger. They're more often lymph node positive. They're often higher grade with more aggressive subtypes like HER2 and triple negative subtypes. So interval cancers we don't want those. We want to find cancers when they're small and ideally at screening.
Why is it different from one province to another?
Because our healthcare systems are run provincially.
Right. Wow.
And so, BC's good. Well, I mean, and in British Columbia, if a woman has dense breasts, C or D category, and gets a requisition from her doctor, she can have ultrasound of both breasts, a screening ultrasound to look for what might be a cancer that was missed on her mammograms. In other provinces, even the ones that tell women their density, their health and provincial health insurance is not covering the screening ultrasound.
Wow.
So that needs work.
Okay. How well informed are the GPs?
Not very. There's a lot of work to do, and that's part of, you send a woman a letter saying you have dense breasts and her GP doesn't know what that means. So there needs to be a lot more education. British Columbia did put some information on the BC Cancer website, but it's not, the wording is very carefully chosen, and I think they're not disclosing all the information. The other problem for family doctors is, they've got to be a jack of all trades. They've got to understand all kinds of illness, and they can't go into depth in every single area. So they rely on a committee that's called the Canadian Task Force on Preventive Healthcare. And this committee issues guidelines about screening, not just breast cancer, but prostate cancer and other cancers and other health issues. And the committee has no breast cancer experts on it. They cherry-picked the literature that the scientific literature that they were willing to consider when they were looking for breast cancer guidelines, and they left out a lot of stuff. And so they came out with recommendations that are not optimal. And family doctors who think, oh, these guys are experts, they don't realize that the guidelines are not optimal. So, for example, the task force has said women shouldn't have routine screening until they're 50, that women should only be screened every 2 or 3 years after 50, that family doctors should not do breast exams as part of a physical, and they're even saying women shouldn't do breast self-examination. And they're saying that women with dense breasts don't need any special attention. So these are bad on so many levels. I mean, I could spend an hour talking to you about the task force and the data they looked at and why it was wrong. They rejected input from experts. I was one of the people, and colleagues who I know were also nominally consulted, but it was a sham, and all our input was ignored.
But that piece of information that you've just shared is so valuable for the person who's advocating for their own health,
Mm-hmm.
right? Not knowing that there's this, task force. And when you go to your GP and they're giving you this information and you're relying on them to be, whether it's upfront or thorough or, and accurate. And
there was a lot of kerfuffle when the task force last came out with their guidelines. Was December 10th, 2018. And there were op-eds and editorials, and Dense Breast Canada actually posted an online petition, which I don't know where it's at now, but the last time I looked, there were over 71,000 signatures, and it was a petition to the Federal Minister of Health, mm-hmm. Urging her to reject these guidelines. There were letters written to every provincial minister of health, every provincial screening program, and those that did reply all said something along the lines of, no, we're doing everything right because we're doing what the Canadian Task Force says to do. So we were interrupted in our attempts to, try to get working on that and fix it by the pandemic. But women need to know this so they can advocate for themselves.
Mm-hmm. Thank you. How do you stay within your own integrity, and when things that you see, particularly in this task force, that they could do more? How do you deal with your own sort of self, your emotional health when it comes to that?
Well, I'm not alone. I have, there are other colleagues who are in the fight.
Yes.
It is draining, but you just got to keep plugging. Right.
Now, does this have anything to do with at all, like women's health? Is this also like a gender sort of thing? Does that come into play at all?
No, no. I mean, I gave a lecture actually last week to a large group of doctors, and one of the questions was, were there any women on the task force?
Uh-huh.
The task force doesn't recommend ideal prostate cancer screening either. So it's not like the guys are getting all the good stuff and the women aren't. There are lots of issues with disparities in women's health, but this is not one of them.
Okay, well, that's good to hear. Yeah, that's good to hear. So what could you say, how has this sort of shaped your life as a physician, as a person, in terms of breast health and, your advocacy with dense breasts, but as a whole, breast cancer? How has that shaped your life? What have you learned from this experience?
Can't say I've learned anything. I mean, I've learned how hard it is to make change where it should be made.
Right.
But that's too deep a question for me. It is my life,
Yeah. You don't form any, apart from the ladies who run dense breast, it's not like you're forming relationships with patients. You don't have that long-term relationship with them.
Not long term. I mean, I have a very intense relationship when I meet them to do their needle biopsy.
Yes.
Sometimes I see them afterwards in routine follow-up. But I'm not like a family doctor that, you know, has a 25-year relationship with all of their patients.
Right, right. Well, in private, you were saying to me that you didn't feel what the work that you did was courageous. And I know I love your humility.
The women in Dense Breast Canada are courageous.
I get that. Of course, I get that. I empathize with that. I completely agree. But I also think you are as well, because you're using your voice. You don't have to do what you're doing, right?
No.
You don't have to. And perhaps this might be an extension of who you are in terms of the way you serve humanity. And that's why you might feel that way. I don't know. Right. But it does take a certain individual to stand in their truth, to be truthful, because we don't really value truth in our culture. That's really hard to value, you know, especially what's going on around in the world right now. We're trying to figure out where's the truth. And what you've talked about, and I've listened to you, and there's snippets of areas that we still need to clear up, fill, you know, make those gaps smaller so that we're all connected, so that everyone that you work with and, you know, are all on the same page, you know. And that's, to me, I think that you're commended for. I really appreciate like your generosity today.
My pleasure. It's not generosity. People are going to see this blog and they're going to learn about dense breast. That's what it's all about.
Exactly. And thank you for doing the work. I really appreciate it.
You're welcome.
From my heart to yours. Thank you again for joining us and for educating me and our viewers.
Lovely to talk to you, and thank you for doing what you're doing, because that's going to get the word out.
Excellent. Thank you, Dr. Gordon.
Okay. My pleasure.
Okay.